Mr. Chairman, distinguished guests from abroad and faculty and ladies and gentlemen, I thank the organizers for giving me this opportunity to participate in this wonderful meeting. And what I will be presenting you is a simple topic of diagnosis and management of autoimmune myasthenia gravis. I mean, that is what I thought, but in the process, the differences between our practice and the Western practice will probably emerge. I'm sure there is a mixed audience, so if you find it simple and repetitive, please bear with me. I will first talk about the diagnosis and then the management. But before we go to that, we must look at this video of neuromuscular junction. This is the neuron, and this is the axon, and this is the muscle, and then this is the axon terminals here, and this is the neuromuscular junction or synaptic terminals here, and then you will see this is the neuromuscular junction, this is presynaptic terminal, and action potentials are formed here, and these are the calcium ions, which are white in color, and they go into these channels, calcium channels, and they in turn activate these vesicles, and they release acetylcholine quanta. And these quanta So these, yeah, why is it not running now? Yeah. So in turn, there's no way I can fast forward it, please bear with me. So now these calcium channels will activate the synaptic vesicles, and they will release acetylcholine, which will go to these receptors, and these are the acetylcholine receptors where they will be lodged, and in turn they will activate the release of sodium and potassium ions, which will generate the action potential. Yeah. Now, in myasthenia gravis, what happens that these synaptic terminals here, the antibodies are blocking them. So when the acetylcholine quanta appear, they are not able to unite, and therefore the action potential is not generated, and therefore there is some sort of a fatigue. So myasthenia gravis is the commonest neuromuscular transmission disorder, and it results in muscle weakness of specific muscle groups. And because there has been so much improvement in the diagnosis and management that the name myasthenia gravis is probably not correct. It is no more a grave disease. Now the mortality has gone down from 30% to 3%, and so we should probably have a better name for this disease. The clinical picture is that of fatigability, fluctuation of weakness, ptosis, diplopia in 2/3 patients, chewing and swallowing difficulty in 1/6 patient, limb weakness in 1/10 of the patient, and limited muscle groups like neck, tongue, hip flexors, and ankle dorsiflexors are often involved. Symptoms are of mainly ocular, weakness, and fluctuations in early stage. While watching television, patient may complain of blurred vision, driving in bright sunlight. He may be helped by a goggle, which may reduce diplopia. The pharyngeal weakness may result in difficulty in eating, and generalized myasthenia gravis results in facial and oropharyngeal and limb weakness. Physical signs are again, they are fluctuating weakness in specific muscle groups. There may be asymmetrical ptosis, there may be medial rectus palsy in the early stage. There may be a surprised look, which I'll show you, and then there may be nasal speech, chewing and swallowing difficulty, dysphagia without dysarthria, hanging jaw, and a transverse smile. This picture shows to you, this is how this smile becomes altered, and the ptosis is asymmetrical ptosis here, tongue atrophy you can see, person cannot burrow his eyelashes deep, and this is the surprised look because of the frontalis contraction. This anxious look is quite typical of myasthenia. Sometimes patient's jaw starts hanging and then they support it like this, and sometimes head starts dropping down, and there is a head drop syndrome is also known as. And these are the subtypes of myasthenia gravis which are well known. In adults, we have children, more common with the ocular myasthenia. In Asia, we have more commonly children, and in adult it is more commonly in the Western population, mainly the adults are affected. This may be a difference between, but I don't think it matters when you examine individual patient. Then there may be early or late myasthenia. Early is below 40 years and associated with hyperplasia of thymus, and late after 40 years, and they have mainly acetylcholine receptor antibodies, and some other antibodies are known. Thymoma can also result in myasthenia, and there are other number of antibodies are associated, which are mentioned here. Now we are recognizing MUSK-positive myasthenia gravis, and that is a specific group which I will probably mention. And then there is seronegative group of myasthenia gravis. Now, diagnosis is very simple. Now, we do not do tensilon test because of the cost and other things. We do prostigmine test, and our protocol of prostigmine test is shown here. Choose the target muscle, give atropine and neostigmine, 1.5 to 2 milligram intramuscular, and then decide your target. How are we going to define? And that may be ptosis, diplopia, arm abduction time, neck or leg raising, swallowing, single breath count, chest expansion, pupil and heart rate. And these are monitored every 15 to 30 minutes for 1 hour. And this is a very good test, but quite a number of times this test is false positive, and we have committed mistakes. In the end of my presentation, I'll show you the most recent mistake or most recent confusion which we had. And sometime in patients with brain tumors, they may be positive, which I will show you later on. Ocular cooling test or ice pack test is a very useful test. A patient has got ptosis. You give a bag of ice on the eye for 2 minutes, and you can see the improvement in the ptosis. Acetylcholine receptor antibodies are confirmatory in the clinical context, and they have in ocular myasthenia they are positive in half the cases, and generalized myasthenia in around 80 to 90% cases, and in thymomatous myasthenia they are positive in nearly all the cases. The antibody titers are low in ocular myasthenia and high in generalized myasthenia, but the antibody titers do not determine the response, and they are not useful other than for prognostication. They are useful for the diagnosis. False positive antibodies can be found in liver disease, SLE, ALS, penicillamine myasthenia, and inflammatory neuropathy. RNS test is very useful for the diagnosis, and these are the machine setup, but now the machines are so different and computerized that you don't have to remember, but those who are interested, the machine setup is mentioned here. But when we put in a needle for doing examination, sometime if you see the variation in the motor action potentials like this, then you wonder that it may be a case of myasthenia, and in that case one must do RNS study. So this is a very useful, suggest one more evidence that you do while doing an EMG examination. If your hands are steady and there is a variation in the amplitude of the motor unit potentials, you can think of this. The method of RNS test is shown in this slide, and this is how we stabilize our. We don't use any machines or any splints to immobilize. This is our method. This is how we stabilize. This is the ADM. This is the deltoid. Deltoid, you have to sit halfway. You have to sit on the patient, and you can get a reasonable decrement. This is the trapezius. He is one of our residents now. He's become a faculty, so he's posing for this test. These are the electrode placements for RNS study. This is the nasalis, just active here, reference here, stimulate from here. Then we can do ocular, orbicularis oculi, trapezius, deltoid. You stimulate from the suppressed clavicular point and record from here, abductor flexor carpi ulnaris, abductor digiti minimi, and so on. So these are which muscle you want to do, you can do, but one has to be comfortable and experienced in doing a few muscles which give you the best yield. The important thing is when we do a decremental response, we should be very careful to see the bimodal response. The response comes down and then rises up. This is very typical of myasthenia gravis. And then when we do a resting recording, you get 9% decrement. You do 10-second exercise and then you get facilitation. The decrement becomes less from 9 to become 6. And then you do 3-minute rest, then there is 11% decrement. So this is known as post-exercise facilitation and post-exercise exhaustion. So this is the protocol one has to do in all the muscles to document the decremental response. But then one has to be very careful that we are doing the decrement in the proper way. If there is suboptimal stimulation, electrodes are moving, or one is not very careful, or your hand is moving, then we can create pseudo decrements. These are the pseudo decrements which we have created in the lab to demonstrate electrode movement, unstable electrode, submaximal stimulation, and misplacement of the electrode can lead to decrement. So while doing the RNS study, one has to be very, very cautious and steady and see a predictable response and then a slight rise. If that is happening in that way, your decrement is done properly. Well, we all know that in RNS study you get a 10% decrement. But this is just, by the way, this is the false positive prostigmine test in a patient with third ventricular tumor. This patient prostigmine test was positive. So when you do a positive prostigmine test, see the overall clinical pictures. Not only one test, but we should have multiple tests confirming the diagnosis, then only we should accept it. Now, when we are doing the RNS study, then so many muscles I have told you that we can do it in ADM, we can do in the supraspinatus, we can do in the deltoid, facial, nasalis, and so on. Which muscle to choose? Now, when you choose a muscle, one has to be careful that you are able to perform the test nicely, patient is able to accept it, and you are getting a good yield. If all three are happening, then that is the best way. That is what we look. So, we looked at patient discomfort and we looked at deltoid, where the deltoid was the most painful because you have to give high stimulation, you have to stabilize it, and the patient does not accept it very easily. It's not very easy to perform this test. The next was nasalis. Nasalis also patient did not accept very much. Then diagnostic yield. Diagnostic yield was maximum with deltoid, nasalis, and trapezius. These are the percentages. And technical ease, how many times you repeat it and how comfortable you feel. This also we evaluated. And we found technical ease was minimum with deltoid and serratus anterior. So after doing all this, we made a conclusion that look, if there is a limb myasthenia gravis, then abductor digiti minimi easiest to do and gives you minimum yield. So if you are getting this positive, straight away you do one more muscle and diagnosis is clear. Ocular involvement, then you do nasalis and trapezius. And ocular involvement, you can do nasalis. So in this way, we can see a patient and decide which muscles are going to give us the best yield. These are our study in which we evaluated different muscles and saw their results. Now, this slide tells you that general rule is that 10% decrement is suggestive of neuromuscular transmission abnormality. But all the muscles have different degree of normal decrement. ADM has 7% decrement, orbicular is 8%, deltoid 13%, nasalis 9%, serratus anterior 14%. So we must keep this in mind. If you are getting 11% decrement in deltoid, be careful. So this is just to tell you that. But the rule of thumb is 10% decrement. But in deltoid and serratus anterior, they may have about to 12 and 14% decrement. So one should keep that in mind. Now, I told you that you do a resting stimulation, then you do exercise facilitation, and then you do exhaustion study. Now, should we do all this or just do simple resting stimulation in all the muscles and quickly and decide? Now, this was all answered in this beautiful study published in Muscle Nerve. And what was the conclusion is that instead of doing 3 times stimulation, just do 1 time stimulation and do a large number of muscles, and then the yield may be much better. So if you are getting 2 muscles showing you decrement, then you can diagnose it. So nowadays we are not doing facilitation exhaustion studies, we are just doing resting stimulation in large number of muscles, and when we get to double result positive, then we take it as positive of neuromuscular transmission abnormality. Yes, you can do facilitation when you're doing a project, you want to look at the reserve, you want to see the prognosis, then these studies are useful. From diagnostic point of view, I think one can do away with lengthy protocols. Then variables affecting RNS are temperature, exercise, location of the muscle, and drugs. Now, then there is single fiber electromyography. Now, this is also is practiced, and single fiber electrode is a special electrode where you record from this point. This is 25 micron area, and one has to be very experienced to do this study. And we have learned and not mastered, but we have learned and we do it. And we did a study also on single fiber and RNA study in our lab. And this is interesting thing is, look at the variability of motor unit potentials. This is the variability, this is the normal, and this is another. Now, you can do the single fiber electrode, which is very expensive. So one can take a facial needle and do the single fiber EMG with that. Now it is known as jiggle. So you can do, but you have to be more experienced than a single fiber expert to do a single fiber study through a concentric needle. But those of you who are interested and want to devote time, you can even use a facial needle and use that. Now, fiber density is not relevant, so I'll not go. This is the study which we did for our own learning, that what is the use of single fiber in our practice. So we did RNS study and we did single fiber study. And then in 30 patients, and 2 patients cannot cooperate. If the patient got a lot of weakness and fatigue, then you want him to activate, then he will not be able to do it. So then you have to do a stimulation protocol, which is again difficult. A separate thing you have to know. So RNS was normal in 6 patients. In all these cases, single fiber EMG was abnormal. So single fiber EMG is useful in limited number of cases where decremental response is not coming. So it has a limited, but in India, patients often come quite late and in advanced stages. So I think for our practice, a good RNS study is good enough. Acetylcholine receptor antibodies are good enough. But if you are interested, you can learn single fiber and practice it. Now this slide shows the comparison of different tests which I have mentioned so far. For this is ocular, so we have got prostigmine test, which is positive in 60 to 95%, and ice pack test, which is positive about 90% cases. Single fiber EMG, well, it is very, very sensitive, provided one has to do it. And Dr. Stolberg could do in any muscle with at most ease, but then you have to have a lot of experience. Immunological response, acetylcholine receptor antibodies, positive in 50% of ocular myasthenics. Then oculopharyngeal and generalized myasthenia. Here you see RNS study 60%, single fiber 99%. Acetylcholine receptor antibodies in generalized myasthenia are 85%, and MUSK are positive in 40 to 50% of antibody negative. So this is the yield of different tests. Coming to the management. Management of myasthenia gravis is symptomatic, that is remove the trigger or and provide the supportive care, and use acetylcholine receptor antibodies for symptomatic treatment. Short term, we may use plasma exchange and IVIG, and long term, thymectomy, corticosteroids, and other immunosuppressing drugs are used. This is the therapeutic agents which are used in myasthenia treatment. The mestinon or pyridostigmine we use, and the dose is mentioned here, and it affects begins in half an hour, and it is a symptomatic treatment. Plasma exchange IVIG are used when the patient worsens suddenly or you're preparing for surgery, and it is used in crisis or in exacerbation. Prednisolone is most commonly used, 1 milligram per kilogram. Effect appears in about 3 to 6 weeks. Azathioprine, mycophenolate, cyclosporine, tacrolimus, cyclophosphamide, rituximab. These are other drugs, and they are second or third line drug and used in selected cases, and some of them are used for steroid sparing. Now, removing the trigger is the most important. And before we go to give steroids, we must take care that the patient does not harbor any infection. In India, where tuberculosis is common, there may be infections, so one should be very careful before starting steroids. And we had a patient of CID, not myasthenia, but a case of CIDP, where we treated with steroids, and then the patient succumbed to hyperinfection because of strongyloides stercoralis infection. So what we learned is that before you start steroid, take care of the potential infections and control them before we start steroids. Thymectomy. Now, thymectomy provides remission or improvement in myasthenia gravis, especially in young females, early in the disease. And transexternal is preferred, although now there is a fashion for keyhole surgery. People want to do video-assisted thymectomies. Surgeons are more keen to increase their series, but we quite often suggest that go for transsternal. Worsening may continue for years after thymectomy, and a randomized controlled trial is in progress. We are looking anxiously for the results about the role, which will give us information about the actual benefit is there or not there because of thymectomy. Late Newsom Davis had started the trial, and I hope it is in progress. But at the moment, American Academy of Neurology has provided practice parameters, and there is a positive association between thymectomy and myasthenia and outcome. There's 2.1 times higher likelihood of getting drug-free remission, 1.5 times higher chance of becoming asymptomatic, 1.7 times chance of improvement. So there may be a positive effect. But still, the Academy recommends that this is a class 2 recommendation and is optional if patient also wants and the doctor also wants, then one can go for thymectomy. And these are the thymic hyperplasia, and these are thymomas. If there is a thymoma, of course, there is no question, person has to undergo thymectomy. But more important, the patient in our practice at least, patients with myasthenia gravis have comorbidities, like, which I have tabulated here in our 64 patients at that time. Seizure, stroke, vitiligo and rheumatoid arthritis, thyrotoxicosis, tuberculosis, diabetes, and hypertension. So when we treat myasthenia, then these disorders also have to be managed. And quite a number of times when we manage these conditions, quite a number of times the myasthenia patient may worsen because these drugs may lead to worsening of neuromuscular transmission. So one has to be very careful, and I would suggest that there are two websites, one is the University of Missouri and Myasthenia Foundation website, where they give you information about the safety of a drug. So when you are in doubt, always better to check before prescribing a new drug. For easy reference, regarding antihypertensive, ACE inhibitors, ARBs, beta blockers, and diuretics, potassium-sparing diuretics can be used. Calcium channel blockers, amlodipine, etc. are a problem and should not be used. The one in yellow are not to be used. Anti-epileptic drugs, these valproate, levetiracetam, lamotrigine, and phenobarbital can be used. Carbamazepine, there is some reports of worsening. Antitubercular drugs can be used. Streptomycin, amikacin, and quinolones should be avoided. In antibiotics, ceftriaxone, trimethoprim, and penicillin can be used. Then aminoglycosides, of course, to be avoided, and azithromycin to be avoided. But this is a small list, which is the common drugs, but others we can always verify. Corticosteroids bring relief in about 75% patients, and most of the improvement occurs in 6 to 8 weeks. You can start low dose or high dose. If we give high dose of steroid, there is 30% chance of worsening in 1 to 2 weeks. So our policy is to start with low dose and work it up. And preferably keep the patient in close follow-up, because sometimes patients after steroids become worsened. And in that case, one has to use IVIG and plasma exchange. Corticosteroid worsening occurs in 30% in 1 to 21 days after improvement, and one should keep a close watch, change the acetylcholine receptor inhibitor dose and plasma exchange before steroid, or start with low dose regimen. Azathioprine, quite commonly we use, and it is most frequently used immunosuppressant, but it takes long time. It takes 6 to 12 months to act. And we start with small dose of 50 milligram, but increase it by 50 milligram weekly to 150 to 200 milligrams. Taper to the lowest possible dose. There's no point in keeping it a high dose. Bring it down when the patient is able to accept. Side effects like liver, blood counts, and gastrointestinal dysfunctions have to be monitored. Mycophenolate is open question whether it is beneficial or not, but at the moment it is being used by the specialists, hoping that it is easy to titrate, there's not much less toxicity, but there is no additional benefit according to one study. It has no steroid sparing effect in another study. However, we have to learn more about the use of this drug. We also use it more commonly in renal transplant patients, but sometime now neurologists are also trying to use it. Cyclosporin, again, it comes mainly from renal transplant patients, 5 to 6 milligram per kilogram, 12 hourly. Effect begins in 2 to 3 months, peaks in 6 months. We have to monitor blood pressure and serum creatinine, and sometimes it produces seizures and behavioral abnormalities. Plasma exchange, if you have facilities, it is very good, but generally we do it in desperate situation, because sometimes there are venous access problems, sometimes infection related problems, sometimes venous access is a problem. So we prefer to use IVIG than to plasma exchange, but in some cases, selected cases, we have used it. IVIG, of course, is used, and relief occurs in about 1 week's time and lasts about 5 to 6 weeks, and some side effects are there which are well known to you. Pregnancy is a special problem for myasthenic patients. Quite often patients are referred because of pregnancy to our institute, that the patient may need a ventilator and admit him and so on, but then one doesn't know what happens to them. You can't predict an individual patient, but one third of these patients improve during pregnancy, 1/3 worsen, and 1/3 remain unchanged. But who are those 1/3? You can't say that. So this is the actual thing. The first pregnancy results in first trimester worsening, and subsequent pregnancy result in third trimester worsening is reported by some experts. Well, we have some experience of managing pregnancies and myasthenia, but not a very large one to give you my own experience here. Complete remission is possible in late pregnancy. Pregnancy is difficult to manage in early myasthenia gravis, and if you have a choice and a patient consults you, better to tell that you first stabilize your myasthenia and then plan the pregnancy rather than go ahead just like that. Therapeutic abortion is seldom needed. Oral cholinesterase are the first line treatment. IV one should not give because it may lead to uterine contraction. Prednisolone, plasma exchange can be used. IVIG is to avoid it in the first trimester. Immunosuppressants and magnesium to be avoided. Cesarean section should be done only for obstetric reason and not for myasthenia. And second stage may need forceps and suction evacuation. Forceps may be needed, and breastfeeding is allowed, although the drug, acetylcholinesterase antibodies, go in the milk. So, ladies and gentlemen, to conclude, I'd like to say that for diagnosis of myasthenia, one has to have a high index of suspicion. It is very rewarding to treat these patients. A diagnosis is based on acetylcholine receptor antibodies, RNS study, and single fiber EMG is not necessary for most of the cases. Thymectomy should be done in all the cases with thymoma, and it may be done with thymic hyperplasia if the patient wants and the physician also wants, but there is no strong evidence in its favor at the moment. A trial is underway, and maybe we'll know the results. Steroids and azathioprine are commonly used. We also use azathioprine most commonly, and plasma exchange IVIG are used for acute worsening. MUSK-positive group is very, very important. Now we are antibody negative cases. We are getting MUSK antibody positive. I have about 6-7 patients in my follow-up, and they are very sensitive to acetylcholine receptor antibodies. So one has to be very cautious with the dose, and they respond to steroid. So sometimes they have to be given a higher dose of steroid, and they respond. And while you are increasing the dose, there's always a debate, why not to go to secondary immunosuppression, why not go to tacrolimus, why not add methyl mofetil. So these questions are done, but what I have felt that you just hold on, increase the dose of steroid, and most of these patients in my experience have done well. ICU support is vital. I have not been able to talk about ICU management. These patients, given artificial ventilation in this difficult situation, are great. And when we put them on ventilator, we stop all anticholinergic drugs. Stop them for a week or so, and when we start weaning them, then only the drugs, mestinon or other drugs, are increased, and not before that. So as I said, myasthenia gravis is no more a grave disease, because these are the achievers in our society: Amitabh Bachchan, Tendulkar, John Carter, Sir Peter Wright, and John Spencer, they have achieved so much. So it is very heartening that people, in spite of myasthenia, in spite of thymectomies, have won laurels for themselves and their country. So lastly, I would like to mention that we all learn from our mistakes or difficult cases. Now, what we know that myasthenia, there is ophthalmoplegia, neck drop, and interresponse to prostigmine test. So this is what happened. This was a child who was admitted with neck drop like this, and eyes were not moving at all. Can you see that? Yeah. His limbs were okay, but eyes were not moving at all. So our resident did a prostigmine test. And when he did the prostigmine test, he came running that now, sir, his eyes are moving. So he's a case of myasthenia. We did an RNS test. RNS was not coming positive. Now there was a dilemma that eyes are moving on prostigmine and patient RNS test is not positive. We thought it is some technical difficulty. We repeated it a number of times. Weakness is there, but RNS is not showing decrement. So then we did the rest of the examination, and then it is very interesting. Oh. Now it's the last slide. Please don't bear with me 1 minute. I'm sorry. Yeah, these eyes have started moving nicely after giving 1.5 milligram prostigmine. And here you can see the neck drop. He is not able to hold his neck at all. So So 6-year-old boy, flaccid quadriparesis after 15 days of fever, bulbar respiratory involvement, pupils normal, external ophthalmoplegia, neck drop. Prostigmine test, eyes shows improvement. But when you do the nerve conduction, we find, oh my. So then you see CSF protein was 62 milligram. And nerve conduction showed slowing of terminal latency prolongation in one nerve and a conduction block there in one nerve. So neither the diagnosis of GB syndrome was 100% satisfied nor myasthenia. We treated this patient as GB syndrome and we gave him IVIG, and patient on 7th, he needed ventilation for 7 days, and now he's absolutely fine. So sometime, in spite of all your knowledge and examination and evaluation, sometimes there is a dilemma, as in this case. So we should be very cautious, and we should collect as many evidences as possible for in favor or against a diagnosis. So, ladies and gentlemen, this is a beautiful picture, and we should keep the overall picture in mind. This is not the trees only. There is a face here also. So we should see the patient in totality. Thank you very much.